So I don't have any disclosures to make in terms of financial arrangements related to the content of this activity. Today, the topic is strategies for what has historically been called relapse prevention, and now we're trying to move towards the wording of recovery planning. As it turns out, that's the terminology that many patients and then peers advocate for. So I'm trying to make that shift myself. Please forgive me when I miss it. And I also want to say thank you to Dr. Lindsay. I've borrowed a few of her slides to adapt for this topic. So our learning objectives today are first to describe classical conditioning as it relates to substance use, to provide a brief overview of foundational behavioral principles that are related to relapse prevention recovery planning. I'll just say recovery planning from here on out. And then most of all, to review the most easily implemented modular interventions for recovery planning, because some of the input that we've gotten on this lecture is that the pieces that the providers value the most are kind of what could I do in under 10 minutes, with a patient in my office who maybe doesn't have access to behavioral health or is not willing to see a behavioral health provider. So I did want to make sure to include enough of the theory that, that you feel comfortable adapting it for the patient and explaining the rationale for the patient. But what we'll really focus on today is, what are these really straightforward interventions that hopefully can help your patients who are ready to start making these changes. And this is all from the cognitive behavioral CBT for relapse prevention curriculum. So just to sort of put this into place, uh, looking at the trans-theoretical stages of change model, I'm pretty sure all of you who are here are familiar with that, but just generally, this is the conceptual model that helps us to place a patient on the sort of spectrum of change where they are in terms of their readiness to change around a health habit, health behavior. And what we're looking for in terms of the right timing for recovery planning skills is right in between action and maintenance. So in other words, when people have already made some kind of a commitment to change and they're already starting to make changes that are real in their lives, that it's not just kind of the preparatory stage. And the main thing here is to avoid foisting recovery planning skills on patients who are still in pre-contemplation or contemplation. In other words, are either don't think there's a problem or still kind of mulling it over, because there's just not really a place for those skills to go during that stage. But when we can catch them when they're already, starting to work on recovery, or especially if they already have a little sobriety under their belt and they really have something to protect, that's often where we find that these skills get the most traction. So in terms of just kind of big picture considerations as we jump into this, I just want to really note, of course, the ideal situation is that all patients have access to and are really motivated to see a behavioral health provider who can do the full CBT for recovery planning curriculum. But of course, we know that's very rarely the case. So some of those big picture considerations for you all who might be just using these sort of plug and play interventions are that we really want to expect repetition with these patients. That's partly because substance use is so deeply ingrained that it takes a very long time to learn complementary habits. So in other words, habits that they can exchange for substance use, but also of course, because chronic substance use, we do expect to see some amount of cognitive decline in many of these patients. And that makes it a lot more difficult to integrate and retain new skills. Second, we want to be sure to provide a clear rationale for any intervention that we assign. That's part of why it is important to know at least the sort of the foundational theory, because patients otherwise without a really clear rationale for why they're being asked to do this, often will interpret it as, my provider just kind of thought of this on the moment and thought it might help. And that's not very motivating for them when we're asking them to do something that's difficult and requires a lot of resources. We want to be clear that there's science behind it and clearly tie it to their goal and how it's going to help them. Then, of course, with the full curriculum, that every single time that we'd be seeing a patient, we'd be monitoring, how the interventions were going so far. I realize that for many of you providers, you don't know necessarily if and when you're going to see those patients again. So I just want to encourage you that if the opportunity arises, it really helps to provide that sense of continuity and to reinforce to the patients that it's what they do in their own real lives with the skills that makes the difference. When you check in, you follow up, you say, how did it go? That thing that we talked about last time, you help them with any kind of troubleshooting that might have come up. And then lastly, and this is my favorite one, is to praise successive approximations. Successive approximations is just a behavioral term for any kind of small segment of a behavior that can eventually coalesce to a larger positive behavior. So any sort of small step towards recovery, it could be that they just start scaling back their use, even a very small amount, that's something to really celebrate and reinforce. We want to reward that as much as possible. We want to spotlight it, be a cheerleader, and in all these ways, communicate to them that incremental progress is substantive progress. A lot of patients have that idea in their mind that cold turkey is the only way to go, or that they have to take these huge leaps to make recovery real, and that's not the case. Slow and steady tends to be what wins the race. So we really want to support that incremental progress. So in terms of the theory that we do need to know in order to be able to, explain the interventions and adapt them to the patients, classical conditioning is really the bedrock. So if you've had any kind of intro to psychology, you've heard of classical conditioning or Pavlovian conditioning. That refers to Ivan Pavlov, who did these canine studies a couple hundred years ago, where he showed, first of all, that food for a dog is what's called an unconditioned stimulus. So that means that a dog is going to have an unconditioned response to it. That just means that the dog, irrespective of its personal history or any kind of training it has or hasn't had, dogs are going to have all around the world the same response to food, which is they're going to salivate when food is presented. On the other hand, when they're presented with something that's called a neutral stimulus, in this case, a bell, they're not going to have any specific kind of conditioned response unless they have a personal history with it. So unless they've been trained to respond in a way to a bell or have some other kind of historical experience with it, all they'll do is just briefly attend to it. However, what Pavlov did was to pair that neutral stimulus of the bell with the unconditioned stimulus of the food systematically and very consistently over a period of several weeks until the bell became what's called a conditioned stimulus, which produced a conditioned response. And that means that after a couple weeks of hearing the bell every time they got the food, then the dogs would start to salivate just when they heard the bell, even if there was no food present at all. And this is an involuntary response. So it's really that's a definition of classical conditioning, is that it's involuntary. So the body was reacting in the dog as though the food was there, even though it was actually just the bell, this sort of proxy, this association with the food. So that is what we would call, with substance use disorder treatment, a trigger, the bell, right? So that's something that primes the body to anticipate a reward. And a number of involuntary physiological processes follow that priming. Obviously, when we compare the potency of dog food to a dog, powerful as it is, to the potency of illicit substances on the human brain, the difference is, many hundreds of thousands of times more potent for an illicit substance. So, unfortunately, these triggers, the conditioned stimuli, can be formed even the first time that somebody uses substances. And it can be anything in their environment. It doesn't have to be anything nearly as explicit as a bell. It could be what they're wearing, or the time of day, or the people that they're with. That becomes a conditioned stimulus, or it can become one. So it can become this associated cue where, once the body experiences that trigger again, the body starts priming itself to use the substance. So the way I think of it often is that once the substance is presented, it almost like shoots this sticky spider web into its environment, and anything externally or internally that's proximal to the use can get stuck to that spider web and become one of these triggers, one of these associated cues. So in terms of how we apply this to substance use disorder treatment, one of the most important things that we're doing with recovery planning is to make the process that feels to patients and their loved ones invisible and opaque, which is, sometimes the triggers aren't obvious at all. It seems like it comes out of nowhere. When the triggers are obvious, it often feels like the moment the trigger appears, it goes straight to the using behavior, and that nothing happens in between. And that's not the case. There's actually quite a number of internal processes that happen in between, as well as a few external ones. But the big ones that we're going to focus on here for our interventions are, first of all, that there is always a trigger. Sometimes it's internal, sometimes it's external, sometimes it's obvious, often it's not. But the greater awareness we can promote around the trigger, the more control the patient has over the behaviors that follow. And really, with this whole chain, this whole sequence that you see here, the overall goal is to promote awareness of each of these steps as they happen, in order to slow the process down, to make it less automatic, to give the patient more opportunities to hit the brakes, even if it's just to tap the brakes, because every time we slow it down, we slowly erode the links in the chains between each sequence in this process. So again, starts with the trigger, then typically it would lead to the thought, the sort of the cognitive, recognition of the possibility of use. Then if it's not interrupted, that leads to the craving, the sort of physiological response to the anticipation of use. And then if that also is not interrupted, to the using behavior itself. So as we talk through the interventions today, I'd like you to think of, each one of them operating at a different juncture in the chain to try to slow it down, or at least to, ultimately to sever it. And there's two sort of pathways that we'll talk about. The first is to actually try to avoid the trigger altogether. That's the furthest upstream that we can go with an intervention. And that is the lowest risk, highest reward when it works for the person's life, is just to eliminate the trigger and make sure that they don't come in contact with it. However, that is absolutely not realistic for quite a lot of patients and quite a lot of triggers. And even if it were possible, usually if we're trying to eliminate all triggers, that makes a person's life very narrow, very small and unsatisfying. Their quality of life would suffer even if they were able to stay sober. And that's not ultimately what we're trying to do. We're trying to promote their quality of life in a way that supports their sobriety. So as we go through, we'll talk about that first pathway of sort of doing the end run around the trigger, and then we'll talk about several interventions that operate at different levels of these chains to either slow it down or to sever that juncture of the chain entirely by making these processes less automatic and more proximal in a patient's awareness. So one of the most important instruments that we use for this is the functional analysis sheet. I realize that this looks busy, but I really want you to encourage to consider just looking at the first two columns and using it as a conversational guide with a patient, because this is a conversation you can have in less than 5 minutes that can be incredibly helpful to patients who have not had the opportunity to reflect on their triggers before. So you'll see the first two columns are just external and internal triggers. So that's the who, where, and when of their use. And then also, what are they thinking? What are they feeling emotionally? And what are they feeling physically proximal to the use? And even just scaffolding in some of that awareness can actually be pretty pivotal for a lot of patients who have never been prompted before to explicitly identify, what are the antecedents of use, because that gives them a lot more control over either avoiding or reducing, or at least just encountering them differently. So the one of the sort of most direct ways to take that information about triggers is an intervention called stimulus control. And this is that upper pathway where we're trying to either avoid or really reduce contact with the trigger. So this is about making where they spend the most of their time. If it's somebody who's securely housed, that's where they live, a safe space. So this could be, occasionally patients are willing, depending on their stage of change, to just jettison all of their supplies. That doesn't happen that often early on, but many patients are amenable to just placing a little friction, a little space and distance and effort between themselves and their paraphernalia or their supply. So that could be something like helping them figure out where in their house would be difficult for them to access. Are they willing to put it high up in a locked cabinet? So they're going to have to get out a chair and find the key, etc. I had a patient recently who was a very tall person, and they realized that if they rolled their supplies to the back of a very heavy piece of furniture, then it was really hard for them to get out. And again, this doesn't necessarily stop a person from using, but it's a great way to slow down that chain. And again, anything we can do to slow down the process, that is a win. I do want to note, you don't want to have people putting their supplies anywhere on the ground if there are children or animals in the house, obviously. Another part of this, of stimulus control, is just helping them to become aware of more contextual triggers. So for a lot of people, it might be that there's a piece of furniture that they're usually using on when they're at home. It could be around a time of day. It could be some music that's on. It could be, I find, especially with old timers, it might be around a TV show or a series of TV shows when they're using. These are all things that if you can help them make explicit, patients are often willing to try to readjust, whether it's getting rid of the furniture or making sure they have a safe supportive friend over when they're watching that TV show, but just making sure that they're managing the stimulus differently once they're aware of it. So one piece that's important to understand of the behavioral science behind this, as we look at further down the chain, the interventions we can use, is that both rewards and punishments can be used to shape behavior, but they do it in different ways and with vastly different effectiveness. So we use rewards when we want to increase a desired behavior. So a behavior we want to see more of, we reward it when it appears. And then theoretically, we can use punishment to decrease undesired behaviors. Now, something that's very, very clear in behavioral science, across different populations and different behaviors and diagnoses, is that punishment is far less effective and sustainable than rewards. There's a lot of reasons for that. one of the most salient for our purposes is that when you're punishing an undesired behavior, you are not providing an alternative behavior. And something we know about the human brain is that it really is not very good at just saying, okay, I'm just going to stop X, Y, and Z behavior. Whereas it can be quite successful at saying, instead of XYZ behavior, I'm going to do LMNOP behavior. And that's what rewarding desired behaviors does. It's building a different pathway. It's still building an alternative for them to participate in and reinforcing it. So this is something that's important for us to know as providers, but also to communicate it to patients, because patients usually have absorbed that the social stigma and the sort of history of how we've treated substance use disorders in this country, which is to try to punish people into stopping. We know now it doesn't work, and yet it's a really dominant part of the treatment paradigm. So that's often a patient's first impulse, is to try to punish themselves every time they use so that they'll stop using. What we want to orient them to instead is to reward them for abstinence, to reward them for pro-social behaviors, for any behaviors that compete with substance use. A concrete way to do this, and another one that can take certainly less than 10 minutes, maybe 5, is just to introduce the alternatives to use table. And this helps the patient to clarify first what is the trigger, and then also what is the positive consequence of use in that case. So in other words, what would they be using the substance for? Would it be to help them with stress, to help them with physical pain, to help them with anxiety or PTSD flashbacks? Helping them to understand what they're using for in that situation is really critical for them to help generate a plausible alternative for how they can take care of themselves in that moment in a different way. And I do want to be clear, it's important for our credibility as providers that we're not falsely advertising that we're going to find some kind of pro-social activity that's going to be exactly as as potent and fast acting as an illicit substance, because it's not. We can't compete in terms of potency there. But what we are trying to do is get them to think about the general idea, even that they can manage their needs, that they can take care of themselves in ways that honor their self-respect, that are more sustainable, that are more aligned with their long-term values and goals. And this is one that patients, I find, respond very positively to, even if it's just to start brainstorming, that they feel better if they take a hot shower in this situation, or, that maybe they found that this one particular friend is very supportive for them and helps them to reduce their anxiety. So that's somebody that they could call, even if it's just to delay use rather than using. One of the other kind of distract and delay categories, because that's a whole interventional genre that's a little lower on that chain, is just thinking about how we can get patients to wait out the urge to use a little longer, ideally wait it out long enough that the urge goes away, but even to just start driving a wedge between the thought, the craving, and then the using behavior. That's a big success when we can open that wedge up even by a couple of minutes. So urge surfing is a intervention that I find some patients really like, some don't get it at all. So this is really kind of a clinical judgment piece. But the concept or the metaphor here is that when we try to fight urges head on, sort of perpendicularly through willpower, it's similar to trying to fight waves in the ocean. The ocean is usually going to win. You're usually going to get flat, knocked out flat on your back. But if you're able to surf on the waves, so in other words, to kind of ride along with them without falling in and without fighting them, then eventually the wave washes out, and you're able to ride it along. So this is a mindfulness-based approach. It's even though it's very short, it does require just kind of the philosophic background of being able to observe your own thoughts. So that's noticing the urge, watching them rise and fall without responding to them, responding either by capitulating or by trying to fight them, but just by being a curious observer. An absolutely key piece of psychoeducation here, and with any other distract and delay tactic, is to let patients know that urges always pass with time. And it's so key that they know this, because it does not feel that way. Viscerally, it feels as though the only way to stop that urge is to use. But we know that physiologically, the body cannot actually sustain that urge for much longer than 30 minutes. I think it's 45 minutes at the very outside, but typically it's actually more like 15 minutes, even though it feels like an eternity at the beginning. So really helping them to understand, if they can ride out that wave, it will pass. And just like waves in the ocean, it will come back. But every time they surf it successfully, the wave gets smaller and they get more skillful at surfing it. And that's really satisfying for patients to experience. So that's one reason in the full curriculum that we have them fill out cravings and urge logs, where they're numerically rating the frequency and intensity of their urges, because it's really, really an accomplishment for them to see that when they're utilizing this skill, they start to see the numbers go down in terms of how often and how potent the urges are. I do have an urge surfing script that Rachel will send out as the resources, along with resources with this, but there's also quite a lot on YouTube. Sometimes I'll just go through them with patients so that they have one they can use themselves. So I wanted to move to high-risk situation planning, and there's sort of a paradigm and then some concrete interventions that go along with this. And I know this sounds very simple, and I always acknowledge that to patients, but it can be an absolute game changer if people put it into effect. And that's just the idea that people who have been using a lot, they've spent a lot of their time in high risk situations, so situations that are associated with a number of complex triggers, a number of vulnerabilities to use. And the more we can shift them out of time around those people, places, and things that are associated with use and into contexts towards people, places, and things that are not associated with use, the less energy they have to put into, constantly fighting these triggers. So it's really just about how can we get you to spend more time around the people, places, and things that support your recovery, that make it easier for you to stay sober. And again, I always acknowledge it sounds really simple, but then patients who follow through with it tend to be really impressed by what a difference it makes if they just think of it as this sort of choose your own adventure situation where they're constantly choosing between doors that could lead either to a high risk or a low risk situation. And the more they can choose to open the low risk situation door. So a couple concrete ways to do this are to specifically go over a calendar with them. For in-person patients, I just print out a PDF of a calendar, either that goes day by day or a monthly one, depending on what the routine looks like. And we talk about, starting today after this appointment, where are you going to go? Is that a high or a low risk situation? What would it look like if you went here with this person instead? How would that support your recovery? And making it just very concrete, because this is a skill that many people early in recovery do not have, and much of their unstructured time historically has been spent seeking and using the substance. So being able to just concretely scaffold in this skill of being intentional and purposeful about spending their time with safe people, places, and things, this can go a very far way in a very concrete manner towards helping them build that early foundation in recovery. The other sort of intervention in this category is just the high risk situations worksheet. It's really straightforward. You're looking at it right here. This is out of the actual CBTRP curriculum. So this is just talking to them before they leave your office. And again, under a 10-minute conversation, what high risk situations do you anticipate this week? What do you think coming up is going to be hard for you? Have them write it out, and then you two talk together in the office where they get to benefit from an outside perspective, an additional brain. How can you handle this? And sketching out specific responses for what they can do to support their recovery. And the whole idea here is that you just don't want them to have to improvise once they're in the situation. You want them to, take a picture of their responses on their phone, or have it written down and carry it in their wallet. But you want to make sure that they have already thought it through ahead of time and that they materially have it with them so that they don't have to use up all that extra bandwidth to try to figure out how to get out of the situation once they're in it. Again, this sounds really simple, but patients often say that this is quite powerful just to have been able to think through it ahead of time with someone who's supportive and can offer additional suggestions. Now I'm going to wrap up with what I consider one of the most straightforward and most important under 10-minute interventions, which is just to predict what's called the abstinence violation effect. So this is for patients who do have a little bit of sobriety under their belt already, to let them know, if you think back to the trans-theoretical stages of change model, you may have noticed that relapse is actually integrated into that model, and that's there for a reason. Relapse for any kind of change in health behaviors is the norm rather than the exception, for several turns around that wheel. And when we can communicate that effectively to patients, then they're going to respond differently if and when a return to use happens. So the idea behind the abstinence violation effect is that people put so much effort into trying to change this behavior. And then when there is a slip, it's very, very common to have the cognitive response that, it's all for nothing. I might as well go back to the old way. I've ruined everything. That's just a very human kind of reaction to that disappointment. I had one patient characterize it as you get a case of the screw-its, and I thought that was a really great way to put it. Another phrase is you just don't want to let a slip become a snowball, because that's what happens with the abstinence violation effect. It's people just throw all their hard work out the window, or they feel like they already have. so that there's no point not to go back to the way things used to be. So the point here is that just by characterizing it, by predicting it ahead of time, patients will recognize it when it comes up and will be able to be intentional about how they respond. So they can anticipate it, they can plan ahead, what are they going to do when that moment arrives? And that helps put them back in the driver's seat instead of feeling like it's this passive process of just kind of falling into the hole of a slip. So one of the concrete ways to do this alongside that conversation is to just talk through, these are a few ways you could think of a slip that are more or less helpful. And then things to do after a slip happens, which includes don't panic, stop, look, and listen. And you can see in here encoded what we talked about just slowing things down so that the links in those chains happen a little bit more slowly and become more visible. Remember the abstinence violation effect, because truly this is one of those interventions where the power is simply that you've talked about it already so they know what to expect. Then renew your commitment and decide on a course of action. And to make this tangible, typically what I'll do is fill out at some point with the patient some version of a reminder card. This particular one is from mindfulness-based relapse prevention, but they all have some kind of reasons to stay sober. So what's the most important thing for them on the other side of recovery? Contact numbers of both supportive people in their personal lives, and then something like the Pure Warm line or a similar texting line, somebody that they can text or call if they're thinking about using to distract or delay or to not use. Then some specific skill that they have found helpful. For a lot of patients, the most accessible one will be a breathing or some kind of relaxation skill, but you want it to be one that they have tried and that they have found useful to some degree. And then those alternative activities and plans. So that those are those ones that you would brainstormed with the alternative activities tables of what are some ways that the patient can take care of themselves when they're having a hard time that is not about using substances. So again, this is about them not having to improvise in the moment. It's already there in their pocket or in their phone. So in wrapping up, I just wanted to point out that for those of you who have patients who might not have access to behavioral health at your clinics, but who are interested in accessing behavioral health, there's a really excellent program through UNM that's completely free for mindfulness-based relapse prevention. That's the last group there. It's a rolling group. So if they have a telephone or an internet connection that's private, because it obviously needs to be confidential, then they can connect from anywhere. It's totally free. It's run by students who are supervised by experts. I've gotten great feedback about it from patients who have participated. And then if you're interested in learning more about the MBRP model, there's a couple of other links here as well. So I'll stop sharing. And yeah, try to have more of a focus there on the quick interventions and the theory, but there's always a lot of theory involved. So I'm curious if you guys have any questions about that or any thoughts about what this would look like for you to put into practice in your clinic and with your patients.